Okay.
Okay, next week. What vacation are
You guys,
you? Oh. Okay. The meeting before, when all those like. TBI studies from Cincinnati.
yeah,
Since
Yeah.
you're gonna do like stuff.
yeah. You said Monday?
They haven't finalized it, but it's gonna be like after 5, the 4th.
Yeah.
Wednesday.
Any day work. 4th is Monday.
Yeah, so then that's.
No, sorry, Thursday.
Yeah, I thought Monday was the first.
And then
Good
morning.
Good
morning.
Yeah.
Morning.
I'm Laura. Never been down.
Hello.
Nice to
Thank
meet
you
you.
for
Yeah,
holding
no
up.
problem for coming.
Hello.
Oh, for all your.
Good morning.
I appreciate it. Just a minute.
Good morning. Hi.
Nice to meet you. Mon Alvarado.
Yeah.
And,
That's the
he
easiest way
wanted
to never-
to-
It's just. It does default to record.
Those were the surprise. I think so.
That's fine.
We don't always we want to signal that to ground.
Give you lots of green light. But the one says that it's crazy.
Yeah, anywhere.
Ahmad.
So maybe I set up shop, I need a Wi-Fi access. So
Okay.
maybe I see it, maybe I set
Hey,
shop.
Ahmad,
What's up?
can you help Dr. or Conrad maybe
So do you have a
get
flash
Dr.
drive?
Abbasi connected to the.
Yeah, he's gonna join the Zoom and then share his screen.
Yeah, that's the easiest part.
Yeah,
And
so
then all
I,
I need is a Wi-Fi password.
yeah.
Oh, so we do Zoom within our own, yeah.
It's the best way for the
It's the
people
easiest.
zooming in to see the presentation, so they're not just looking at it behind him.
Yeah.
So I would say, whether you take that. And then, where would I?
You
sit?
can either be here or you can be up at the
I
podium.
come
There is a
here
plug up there, so
podium
we
is
should
fine.
work.
Thank you.
Yeah.
Let's go to the.
We just have a look slide.
Should I set up a Zoom on, because I have a Zoom on me, Zoom.
Oh, we have, it's, so we have one because everybody logs in from home also.
Yes. Sounds good.
Yeah, and I told them, and they will be recorded, so we'll see it.
Sounds good, excellent.
That's one.
Driving to Cleveland or something.
Yeah, that one, if you go back. Hey, good morning. All right.
If you want to do, the internal one, I think I can have it Zoom for the provider.
Why? Good, fine. That's why nobody's like doing anything wrong. Everybody's up.
Every time it's been great. I'll be here.
Shaking size.
Morning, everybody.
Morning now.
Hello.
And I think, so.
Yeah.
And then I'll need the photos, so once, we just have a couple of introduction slides, so you can share your screen.
Good.
You saw the.
What do you say?
Yeah.
And there's an info side, and one that can be a side for.
So it's like.
I don't
I mean,
know.
he's even ignoring our conversation. I don't understand.
Okay, well,
Shut up.
Yeah, Dr. Because he knows how to do this.
He's on there.
Where is it?
Okay.
The local was good, but,
Can
No,
I
sorry.
see like
It
C
says a lot, so I think so.
portions, right?
Okay.
And then you order.
Oh, it's just me.
There's a very big menu,
Yeah.
like 50, 60 items. She's probably-
For brunch.
yes.
I know,
That's amazing.
it's nice. And nice.
So the NAMI has like a weird one. Just-
I was gonna say,
And Sunday.
Sunday,
Nice
Sunday
job.
I'm wrapped up, tied up.
Saturday.
Smiling. Oh, Jess. she's on board. I gotta finish being the Easter bunny for my kids' Easter baskets.
That's so much.
Dim sum?
No, the-
Oh, shut up. I've had it before. It's been a while. Nurse.
So,
You're right.
The pediatric attending.
Schuster? Yeah.
She's like, every time it fades off, I get, so
Yeah. I'm gonna write it off as a work associated expense. Yeah. I mean, really.
Do we know, are other people coming or are they,
Dr. Williams is out of town. Dr. Mystery is out of town.
Dr. Nemad is on?
And virtual.
Yeah,
Well, I think it's in-
I think Allstats in town. I don't know if he'll show up.
okay.
I don't know who else.
I
We
mean,
can probably give just a few more minutes. It usually 7:05 is kind of the witching hour.
We were just wondering how many of the attendees are still in town.
Yeah, well, we'll record it and kind of we'll have maybe like a conversation and more like a discussion and a monologue.
yeah,
Yeah, please come closer. Come some friendly.
well, we'll give it a minute. You know, there's an old saying in Germany, Soldatenzeit es 5 Minuten vorher, right?
That means that soldiers' time is 5 minutes before the.
Wait, since when?
Soldier time is 5 minutes early, and I think neurosurgery time is 5 minutes so late.
Wait, what? When
Can be
did you
five.
make this German? Every time you told me that saying was in French.
Oh, well, it's all right.
The French are not kindly, I can guarantee you that. Germans are very, very kindly. As a matter of fact, there is a saying, if your professor tells you come at 9 or 9:30, he really means that. You mean that come at 9, or don't come at 9, come at 9:30, because he's going to start a project that will go from 9 to 9:30, if you don't come at 9.
Yeah, for example, Yothergill, was that way.
But he was in Zurich, yes.
Well, yeah, Yothergill was in Zurich and he would, to his visitors, he would say, come at 8 or 8:30. And he meant that, like either 8 o'clock or 8:30, because in between there, he was in the locker room changing himself. And didn't really want, he wanted a little privacy to change himself. That was just a peculiarity. Well, we've almost got a quorum here.
So let me see if I can get to Zoom, I'm almost waiting here and.
Yeah.
Hey, can we move one of the microphones closer to the speaker? I'm not able to hear.
Needs to make some announcements, okay?
So maybe I just sit down here and it's still trying to get to that Zoom meeting. Okay, it says join.
Recording in progress.
Oh, it's echoing.
A skin egg.
Let everybody
Am
gather.
I still echoing in the?
It's what-
Just comment my.
Nice, that is a nice official act.
Gross.
Yes, yeah. This is just the mic, so to make sure they hear you fine. As long as yours is off, we should.
I'll do it, fine, then.
Okay, I can make the one announcement that I think we have today. So just recently, this publication, Anesthesia for Oncological Surgery, was published by our anesthesia department, and among the chapters were contributions from these four illustrious individuals in our department. Congratulations to everyone who contributed to that. I'm sure maybe more than those four were involved. So thank you very much. I think that's the only announcement I have, and then I'll turn it over. Oh, and then, of course, just a reminder that we do every week, Kelly Gardner is available to assist with manuscript preparation, research ideas, etc. Please work with her whenever possible. Any other slides? Okay, and then we are very lucky to have Dr. Hamid Abbasi. I'm sorry that I can't be there personally for this lecture. I was happy to attend it remotely. Hamid, I'll be there this evening to meet you over dinner. So look forward to that opportunity. And I thought I'd have Dr. Nauta give the introduction because he knows you so well and is there on site. So that's even better than my doing it remotely.
Yeah, it's a great pleasure to introduce Dr. Abbasi. The picture I want to paint of him for you in the introduction is someone who's been exposed to a lot of different cultures, different academic centers, different ideas, and literally in many places in the world and many places in the country. And I think that's been fertile soil for him to, grow into a very independent, innovative kind of person. His background begins with medical school at I think Isfahan in Iran. Then he goes to Germany and is there at Mannheim, gets a PhD in computer science, and moves on to a medical school, then parts of residency in, among other places, Aachen.
Correct, Aachen.
And then, which is right near Maastricht.
It is actually.
Yeah, that Maastricht is the most southern little part of Holland. And then comes to the United States and does a fellowship at Stanford doing, I guess more computer things. And from the Silicon Valley, in other words, and then Dartmouth for a PGY1. And then he came cap in hand to Galveston, wanting to do a neurosurgery residency. And I think we were quite impressed. I mean, here's this person with all this background, and we were not disappointed. He came and not only, sometimes it's hard for people that have an exposure like that to accept working at any place because they're so busy trying to change your place, but they can't function there. I think Dr. Abbasi managed a nice balance between the positive input to UTMB and hopefully many things that he learned there. So, and the program there included rotations at MD Anderson and University of Texas Health Science Center at Houston. He was doing a final year, sort of a practice, transition to practice year, and was on faculty as a junior faculty when a hurricane came, destroyed his house, and upset everything. So we decided that he didn't really need that for his training any longer, and I had no trouble certifying him as someone who was already fully trained. And then he went out in the world, and I didn't hear about him for a while, and then all of a sudden he's surfaced with this rather entrepreneurial center for spine surgery. And the reason for inviting him is, number one, the things that he's doing, but number two, the entrepreneur, what I would call the entrepreneurial alternative to the academic track. And the academic track is certainly one that I've been in. But I'm recognizing that that's not the only way, and it may not be the best way to really innovate if you have some driving forces that allow you to make it work. And I think what I'd like you to notice about Dr. Abbasi is not only what he's doing, but the context in which he did it in terms of that innovative spirit in a parallel path, I would call it, to the academic model. So Dr. Abbasi, take it from there.
Thank you so much. I couldn't get a warmer introduction. Now, we are all have been a child. And when we are a child, we are all thinking that our parents are treating us unfairly. And then once we become parent, we know, how did we survive? I do think that. How did I survive? Same, I think the residency is no different. When I was a resident, I said, oh, everything is unfair. I have to work so hard and so on. And now that I'm training people, I say, oh my God, what a different world. So my hat up to you, Dr. Nata, training so many residents and not going to mental asylum yet. So, but talking about my background is that, when I was training, my residency wasn't like 7 or 8 years. My residency was 14 years. I trained in many places and everything was related. And actually, I did a PhD in computer science with surgical navigation. And I want to tell that because I know there are some words that are very important going around, like robotic, computer guidance, and so on. I programmed those algorithms that are still being used to take your 3D registration from the CT machine or intraoperative OR to transfer to the navigation machine and so on. I remember the first week I was there, I took ownership of our intraoperative CT, and I was doing with that pretty good in my first week because this is what I used to do. Now, I'm saying this because I don't use no robotic or navigation anymore, not because I don't know how to use them. As a matter of fact, when I was in Methodist, the attending, we go to Methodist for lots of spine exposure. They had an O-arm. The attending literally would fight who would get me for their O-arm because I would go and set it up and everything would work well. The reason I'm not using robotic right now or navigation is because the best computer in the whole world is between my ears, and the best robot in the universe is attached to my shoulder, but you have to own it. So if you take anything out of this meeting today is learn it the correct way. As a matter of fact, there's a good saying about Picasso that somebody comes and make cubism and it's perfect and so on. Say, no, go draw a flower and come back, then you have to learn to do open surgery. This is not a question, but I'm not going to teach you open surgery today. I'm just going to show you a tool in your toolkit. I'm hoping that I will add a tool to your toolkit. And if you walk out of this here that Abbasi does, who watched my surgeries yesterday? Okay, no, we did 5 surgeries and we were done at 12:30. We do routinely 1-level fusion in half an hour and send the patient home 2 hours later. No, but if you get out of this that Abbasi can do that, you walk out of here completely with the wrong ideas. Now, what I compare it in, and one of the things I learned from Dr. Nod is analogies. His analogies are out of this road. Somebody needs to write a book about it. But the analogy I would use for what I'm doing here is that if you drive from Chicago to Minneapolis, it's a 7-hour drive. If you are fast, it's a 6-hour drive. If you're reckless, it's 4-hour drive. And if you tell somebody I drive from Minneapolis to Chicago in 1 hour, they think either you're crazy or you don't know what you're talking about, or you're mistaking, or you're confused. But if you know the concept of flying, you know that flying from Minneapolis to Chicago is 1 hour. It is just you're not safer by taking more time. Now, there's times you can fly and it's safer actually, but there are times you have to drive. So this doesn't replace anything you learn otherwise, okay? So, but let's see if I can share my screen here and show you what I want to show you here. I'm going to see if I can share my screen. Yeah, I think I can. I have the permission. So let's just start jump into that. Now, we are small enough of a group. Please, if you have a question, let's just answer the question as we go. Okay, now, who did not know in this room that spine is the #1 for disability in the whole world? I have been following it. In 2015, it was #2. It was #4 in 1990, so it's now #1. But what's important globally, 1990, it wasn't among top 10. In 2015, it was #4, and now it's #1. Globally, spine is #1 for disability. Not the glioblastoma, not the hydrocephalus, not the cardiac reason. We overtook the cardiac for #1 reason for disability. Now, again, we are a small group, and I know I have way more time than I usually have, so I'm going to put it to good use. I want to just get a guess in the room to also understand the power of what the public health issue spine is. How many instrumented spinal fusions do you think are performed in the United States annually? Just let's take a guess. What do you think? Throw a number out there. There's no wrong answer here. Just want to engage you guys. 10 in United States? Not 10 million. Definitely not. So let's go around. 30,000. We went from 10 million to 30,000. 100,000. 200. Well, we're going up there. What do you think? How many spinal instrumented fusion are performed?
150,000.
Okay. Now, society is getting older, right? And spine is a problem of aging society, and it's getting older everywhere. That's why globally it's becoming #1. Now, by the time you're 70 years old, there's only 1 to 2% chance you don't have spine problem. Now, obviously, we try to not do surgery for all of them. Minority of them, they should need surgery, but that minority is becoming really, really big. Now, I am in the 50 to 60 group, so I have back problem. Now, I'm not talking about the work. In your family and friends' crisis, you're younger than I am, obviously, most of you are. But who doesn't know anybody with back problem? So please raise your hand. I want to see who knows nobody, not work, in the home environment. That not, I know you in your family there are back problem. I know Amanda in your back. Is there anybody here that absolutely knows nobody with back problem? So it's a common thing. Okay, so now let's go back here. This is the number. Would you have guessed that? That this is Becker's spine? I have seen some other references that goes from 1.4 to 1.62, but this is what seems to be the number of the instrumented spine. By the way, 3/4 or 4/5 of it is actually lumbar spine. Lumbar spine is very prominent. Now, would you have guessed that? And now you know what you have to deal with. Since my first day of residency, and God knows that's a long time ago, they're saying spine is going to break the medicine. Oh, they're doing so many fusions, so many surgeries, and so on and so forth. This is what we are doing. And obviously, if you go to the conferences and so on, you understand that we are not going to do less spine. We are going to do, if anything, more spine. And this was just in the Journal of Spine. This was just last year. This is the so-called the anatomy of the Cambian triangle. And I'm going to show you a few slides because I think by the time you are in actual practice, you have to master certain things to be able to compete. You know, there's another analogy that the theory of the Red Queen, you know, the evolution. You have to keep the time to be relevant because if you just keep practicing what you're doing, the whole industry passes you and then you become irrelevant just by nature of time, by virtue of time. It is flastered. In the last 2 years, they're exploding. All these papers talking about the Cambian and trans-Cambian approaches. You just go and start looking. This is what I found in 2 hours, all the paper. And I was reading some of that. So otherwise, I could have found more. It is out there. Everybody's doing that. Now, the different names are used, like Wang in Florida using it endoref because he uses endoscope. Then there are some people who call it the differentiation of a TLS. They call tubular TLS. And it goes on and on and on. So let me show you this picture. Dr. Cambian is a son of Iran as well, like I am. He did most of his study in the United States. Actually, he was practicing in Philadelphia most of his life. In about 1970, 1980, he had a, how do I know this story? I visited him, okay? This is 9 months before he died. And I wish I would have recorded that conversation because that was an amazing conversation with Dr. Cambian. Now, he had this is his story. He had a very good urologic friend. You know, when the doctors are hanging out, his buddy was a urologist. And he was just interested, you know, if he didn't have something to do, they would hang out, sometimes see his surgeries and so on. And that's how inventive minds come to play. Like I remember when we were in Galveston, we had a lab. If we had lots of old stuff and, you know, and I saw Dr. Nata there, sometimes we had a, you know, actual head and we would do practice there and so on. We had all these old instruments and so on that they would just give us ideas about what to do. This is how this started. Through the urologic, rigid urologic endoscope, he said, and with his urologists, when they do their endoscopic procedures, he would look into that and he would recognize some spinal structure. And practically, long story short, he recognized there's an area outside, anterior to the transverse process in the retroperitoneal space where you have a safe passage to the disc. The area, this is void of vessel and nerves. And that is how now he used that. He actually did procedures, but this did not caught up in the United States. Now, who hasn't gone to a conference where people are excited about the endoscopy and all this method and so on? All of that went to India, Japan, South Korea, China. And I just was giving a talk at a lab in India. They have been doing it for 30 years. We pretend we are just, oh, endoscopy, we are so good at it and so on. They have been doing it for 30 years because this work of the trans-Cambian approach, and that's where the endoscopy came from, was caught and reproduced, thought in the university and so on for the last 30 years. And we neglected that. Now in the last 15 years, all of that is coming back to us from Philadelphia to Asia, back to United States. And somebody who has done 5 of endoscopy put a big things out there in the conferences and pat themselves on the back. I just met random spine surgeon in India who has done 5,000 endoscopy. And they're really, really good at it. So, but he told me, Dr. Cambian told me that he never thought that the fusion can be done that way because the technology in 1980s and so on wasn't good enough. Now, I'm not going to even talk about the lateral, prone lateral. Who has not heard about prone lateral? Now, I describe, again, there are many names for transcameral approaches. But I call it the anatomic transcriptively oblique lateral posterior lumbar interbody fusion, because there is a oblique lateral interbody fusion anterior to psoas. So these are different things. But this is one approach, and the other approach is that obviously the laterals are very, very prominent. But now the prone lateral are really, that's the hot topic. Everywhere you go, everybody wants to be the first to do the prone lateral. Okay. Have you guys done prone lateral? Do you guys do laterals? XLIF, LLIF, and so on and so forth. Get good exposure to that. The prone lateral is practically doing a lateral approach in prone position. Just the box that just literally just the retractor system comes in two big sets. What if I told you guys that you can do an OLIF, direct lateral, sacroiliac joint fusion, and two other variations of this just with the material that is in this box. And I'm going to tell you how it came that now we could simplify that. Dr. Nada, I really appreciate your stories about Russia, and I still want to do a podcast with you. So we do have a podcast series. Amanda is in charge of that. But one of the things I learned from the history of technology in Russia is that literally they start somewhere and produce something, and then they take the parts away until it fails. In the United States, we have this great thing, we build Apollo and we add until it fails. And then we have the maximum complexity that fails, and they have the simplicity, the minimum simplicity that fails. And then they stay there. Now, they have Soyuz, we have Apollo. Which one is still flying to the space station? Not Apollo. So in 2012, somebody told me, and after all my education, I thought I'm pretty good in spine. As a matter of fact, in the entire state of South Dakota, they would send their thoracic cases to me. Entire state, well, it's not a big state. It's probably smaller than just the Louisville alone. But I thought I'm a good. And then I heard somebody doing in a surgery center fusions and sending the patient home same day. And I said, nonsense. But I didn't just say nonsense. I said nonsense. I want to see it. And I did go there. And I saw that surgery. And I watched the patient walking 2 hours after the surgery to his surgery, after surgery into his car, and then drive away. I saw that with my own eyes. But then I was really impressed. I said, something happened in that moment that I knew something has to change. If this can be replicated, now he was a very good surgeon. By the way, name is Dr. Talley. He was in our podcast. We talked about the history of transcameral approaches. Very interesting story. If you have a lot of time for history, I apologize now that taking so many side roads, but take time for history, okay? Because everything you think is happening now has happened 10,000 times before. But what I saw, this good surgeon doing literally acrobatic, the instrumentation, the setup, everything was so complex. This was something that only a handful of people, this was something that Yasha Girl and DeMonte or some few people could do. Technically, it was very demanding, but like flying the space shuttle, it is very demanding. But how could you make the space shuttle be like airplane? How do you simplify things that everybody can do that? And that is what I did in the last 12 years. Taking the process apart and finding out how you can do it easier and better, and then put it back together. It is not a trivial task, and I'm going to tell you now. What you're going to see is the result of, meanwhile, I have done 1,597 cases as of yesterday, and I have done 3,300 levels. We have published 9 papers related to this. So this is not a handful of tests and studies and so on and so forth. This is a tremendous, I have 32,000 patients follow-ups. So every mistake you can think of, I have done, and I analyze it and find out how I can do it better. I have trained over 50 surgeons and globally and nationally. So we have put a curriculum together. It is like a flight school. As a matter of fact, I'm a pilot. That's a different story. But I took a lot of things that goes into teaching this from the piloting. What does it take? What do you need to know first before you know second? Now, you're all familiar with posterior approaches, where you, for all practical purpose, you strip the muscle off the bone to get access to the spine. And for a long time, this is what we have been doing. Like, I want to get another, maybe go around here this time, like Cliff. Since when have we been starting doing PLF, posterior lumbar interbody fusion? Just throw a number out there. What year did we start doing Cliff? Oh, no. We have been doing Cliff for a much longer time. This is the oldest I practically practice lumbar interbody fusion. Let's go back there. No, nothing is wrong, okay? It's just a conversation. When did we start doing Cliff? What do you think? 1980s. What do you think? You're getting close. In 1950s, in the 1950s, we started doing Cliff because before that it wasn't unified. Now let's go to TLF by Dr. Harms, who, by the way, practicing in Heidelberg. He's still in 90s. He's still practicing. It's actually amazing, you know. He's orthopedic spine surgeon, German, and you have heard of Harm technique, but he popularized TLF because he found out if you go lateral, if you don't put pressure, patient neurologically do better. Well, for that, now what I noticed, lots of us neurosurgeon learn, if you have a chance, scrubbing with ortho, because you get different tool set from them. Lots of us, like what we learn, we do PLF, we call it TLF. For to do TLF, you have to take the entire facet off. If you don't take the entire facet off, you're not doing TLF. And it's very interesting for me, actually, that TLF was popularized in 1980s. So 1 point there for you. That since 1980s, we are doing TLF. Now, for a long time, we have been doing anterior approaches. As a matter of fact, in 1970s, 80s, we have been doing ALIF. ALIF is access surgeon, and I have done over 120 of them, and I scrubbed in, obviously for medical legal reason. You always have to have another surgeon with you and so on. If you do it right, it's a fantastic surgery. If your access surgeon needs 3, 4, 5 hours to do the access, then it becomes a completely different surgery. It's a good surgery for the right indication and so on. And obviously, the XLIF, TLIF by Nuvasiv since 90s, end of 90s, and then now these are all things that you will learn somewhere else. I'm going to talk to you today about oblique lateral posterior lumbar interbody fusion and a variation of that that we call MIS-DLIF. We published our technical papers on OLIF in 2015, our technical papers on DLIF, MIS-DLIF in 2017. And I told you the numbers. So Cambium triangle, these are the two areas that we use for that. Now, I know we have a lab, I have a model, a foam model. We have actually, I have an actual torso cadaver in my basement, in my campus, but I couldn't bring it with me. I think even when I brought the model, the TSA opened because I have a model that even you get the x-ray, it looked like a human spine. They opened that with all my tools and they put a thing there. Imagine if I would have my actual cadaver in my baggage. But when you look at this, the anatomy of the Cambium area, it's defined by the ganglion, nerve root, facet, and end plate. Now, in this view, which is oblique view, the DLIF approach seems smaller, but in reality, that's 4 times bigger than OLIF approach. But because this is an oblique view for the OLIF, the DLIF approach area seems to be much, much smaller. Now, if you do the direct laterals, even regular direct laterals, I'm not talking about prone, you know, that's a very powerful tool. I probably did 50 of that. And I still do the 50 regular in lateral position, and I have done 300 MIS prone laterals. This is my numbers for prone laterals. What you notice that obviously, depending on the levels you are, the lumbosacral plexus is in your iliopsoas, and you have to identify them with neuromonitoring and so on. It's a beautiful procedure, but it's become really hard to do it in 4L45. The reason direct laterals, have you guys heard that obviously 5S1 direct laterals are not possible because iliac crest, but for 4-5, it's hard to do because all the fibers of the lumbosacral plexus is big because the footprint of the cage is too long, too big. Okay, it's not technically, it's very much possible, but it's just the footprint, the big footprint, the same thing that makes advantageous the direct laterals becomes a hindrance to use it for L4-5, and definitely nobody I know does 5S1 direct laterals. Okay, so these two techniques are going to enable you to bypass many steps in the spinal fusion. What are those steps? What do we do in the surgery? Like average lumbar fusion in a private practice in the United States is about 2.5 to 3.5 hours. In the academic, it's always 1.5 hour longer or 1 hour longer because we have to teach you guys. We have to, and then that time we have to take to give you that knowledge that you can practice in the future. Well, we start the incision, we cause bleeding, we burn the tissue, we stop the bleeding, then we move forward. And then we repeat that until we are there where we need to be. Now imagine all of that goes away. Imagine in the first 7 minutes of the surgery, you're already, no, in the first 3 minutes of the surgery, you are where you need to be. In the first 7 to 10 minutes after the surgery, as you watched it yesterday, the cage is in place. So it's no magic in it. It's just you're not doing those steps that in a regular surgery would be required by utilizing one of these two paths to the spine. And very almost cartoonish here, you see what the difference is. In the TLIF, you are practically directly through the facet, whereas in the OLIF, and that's important, you're anterior to transverse process, and you're actually medial to the nerve root in the OLIF, and you're in the retroperitoneal space. Okay, so, and that is exactly where it comes from, that I probably, the urologic friend of Dr. Cameron was looking at the kidney and the retroperitoneal space, and he was bored, and he just put his eye on that endoscope and said, wow, I recognize this. This is something I know. Maybe I can do something about it. 9 out of 10 people would not be in that room, and if they have been, they would have looked into that and said, just moved on, but he didn't. That's why we have transcameral approach. Now, it is important to understand that the difference between the surgery on the right and the left is not just the size of the skin incision. It's about what happened under the skin. That makes a minimal invasive surgery minimally invasive. Because if you put all those little incisions together, then you have the same big, and I say, so incision heals from side to side, not from end to end. All of that is true. But it's not about the skin incision. So let's talk about, did you see that 1.62 million surgeries that are instrumented surgeries that are done? Currently, less than 3% of the spinal fusion, lumbar spinal fusion are done in a surgery center, less than 3%. We can do over 60% of our spinal fusion in a surgery center by number, or just sheer number. This is something that we can talk maybe tomorrow, maybe today, later, and we have to go that direction because of the volume. This is a typical day for me. We just opened the center in Kansas, and people are coming from 3 states there because people need that. And I'm going to come back here, tell you why people need that. So if you want to have a successful practice, it's the right time for you to pay attention to certain things that will make you successful or not successful in your future endeavor. Now, I know, except you want to go to vascular or cranial base and so on, then you don't have any need for this. But if you want to go to private practice, at least 70% of your volume will be spine or more. You need to pay attention to this then. These are all the muscle of the spine that we don't advertise to our patient. When we cut them, we don't reattach them. This is the look back mechanism of the spine that when you cut that, practically rendering all those muscles irrelevant. This is the vascularization of the spine. When you're stripping the muscle of the bone, you're reducing the original vascularization of the bone to 25% of what it used to be. And then you are surprised the bone spine doesn't heal. And when I showed that to lots of people, they think on the left is beautiful, on the right is ugly. For me as a surgeon, it's just the opposite. This is a patient got a 2-level TLIF in 2012. In 2014, got a 1-level adjacent segment OLIF. And in 2016, hit a deer, broke everything. I took the patient back, and you see that I did OLIF is pristine scarless tissue. And all of that contribute to actual recovery of the patient. I'm talking about farmers, hardworking people that go back to work within 4 weeks. This is the MRI of the spine, and you see 2 levels above where I did the TLIF, the multifidus muscle are scarred 2 levels above. So because these muscles are multisegmental. Now, time on the surgery, that's something we have to deal with. Now, every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. If you put all the surgery that are under 2 hours and all the surgery on the above 2 hours together, you're doubling complication rate. And I'm just going to go and show you a few more slides, and then I want to actually show you a video. And practically at this point, I'm talking about 5-level fusion versus 1-level fusion. If you put all of them together, about 40% of our surgeries are done under 1 hour, and 95% of them are done under 2 hours. Now, if you work ever in a surgery center, the anesthesiologist will refuse to do a surgery that's more than 3 hours. So 3 hours is and all the studies that will show, the complication rate goes linearly up until 3 hours, especially in elderly defined by 75 and older, then it skyrockets. So if you get another second thing you get out of here in your future endeavor, do the surgery on the elderly that you can do under 3 hours, because after that, the complication rate skyrockets. This is one of our studies that we did in 2018. All the spinal fusion in one hospital, and about 388 patients. And practically regular TLF is the blue line, and the time on the anesthesia correlated with any possible complication, hospital stay, blood transfusion, pneumonia, ICU stay. I mean, the data is out there. I can forward you the link. But for regular TLF, as you expect, with the higher BMI, surgery become more complicated. As a matter of fact, most of our societies recommend not to do elective surgery as the BMI of 40. But with MIS TLIF, as you see, this is somebody who has done 2,000. He didn't start MIS TLIF yesterday. He had done over 2,000 MIS TLIF, but even in his hand at the BMI of 37, it flips. Whereas we could go all the way with the same performance. Once the tube is in place, it doesn't matter if you go through 2 inch or 4 inch of fat. And we could corroborate that data in another study. 96% of our patients ambulate within the first 24 hours. That's why they can go home. Now, I'm not going to go through this coding and so on, but long story is, this is not what you start. But if you start learning the technique, then you can replicate it. You can replicate it and then make that to that with this under 2 hours. This is not what I can do. Gasco, Dr. Nata, know him, he's perfect. He does many of these surgeries, and grade 2 or 5S1 spondylolisthesis, send the patient home same day. As a matter of fact, he sends his patient home faster. I guess the crowd in the El Paso are tougher than my patient in Minneapolis. But now let me tell you, this is a personal thing as well. I will teach you the technique. This is not about that. And I'm going to show you a 5-minute video after this, then we will discuss it. Now, this patient came 2 states away, and he had this is actual this patient. He could not walk. He could not go to the kitchen to get food. He had some cardiac problem and so on. Nobody wanted to take care of her. And he couldn't go to kitchen to get food. So he lost 45 pounds in about 3 months He was barely above 100 pounds by the time I met her. Okay, and obviously she was a poor candidate before, she was even a poorer candidate after. But in this picture, she doesn't look 100 pounds, does it? She's now 6 months out. She can walk again. She has gained weight again. And it's actually hard to say which one of them is the patient. It's, by the way, this patient in the wheelchair, okay? So if you learn this, you can actually impact patients' life. If 5 of your colleagues tell you they have to die in agony, and I have seen my parent or my home in Iran, my mother and father both had back problems. They couldn't walk. We went to a hospital. They gave them an appointment in 7 years to get their surgery done. Okay, but here in the United States, technically, we just want to be safe. There are certain surgeries that are not safe, but by you balancing risk versus benefit, all of a sudden you can help people that nobody else can help. Now, I'm not going to talk about the technique here because I'm going to show it to you. I'm going to show you a 5-minute video. If I have access to internet, I can bring up a YouTube, and then I'm going to take some questions. But before we do that, let me just go to YouTube. And I'm just going to put there OLLIF X-rays. I'm just going to choose one of the, oh, now you see all my YouTube history. So let's take just a regular, and this is now just talk about the technique, okay? The surgery is done with 2 C-arms. You have a real-time view. And let me go back all the way from the start. This is a 5 minute. So I'm not going to talk about the indication to say ischemic spondylolisthesis. So I'm sure we will talk about indication and so on. This is not going to replace everything. You still need to learn all the other things. But for the cases that this is a good option, that is a very powerful tool. So I think my internet is a little slower here, but you do need 2 C-arms. People who try to do it with 1 C-arm, you're just not going to be efficient enough to go back and forth. And I tried like 12 different ways of how to set up the C-arm in the room so you can really do the surgery. But then we have a set now, pictures, how it's set up in the ward it's supposed to be. So you don't have to reinvent that. I tried actually 15 different kind of draping until I end up with the draping I'm doing right now. One of the things, my advantage is, I'm never happy. So I always try to do things better. Sometimes even things that don't need to get better, I try that anyway. So then I mark the trajectory to the disc in the AP and lateral. Practically, I identify in a true AP and lateral, and sometimes if patient has abnormality like deformity, the C-arms have to do acrobatic to get a true AP and lateral. Then first thing I do, I put the Jamshidi in, I take some bone marrow and mix with my biologic. And we have a protocol for that, how you can do the best mix in what time frame. It's all protocolized. But then I got my bone marrow, my biologics is mixing. Now I'm going to stop here. This is a probe, and I have a sample of it that is insulated all the way to the tip. There's a metal sleeve over it. Literally, I stimulate at 3 milliamp until, and I aim for the pedicle of the level below, and then I drop it over the pedicle to the Camden triangle. And once I am there, I stimulate at 4 milliamp, then the sleeves hold the trajectory, and then a K-wire goes over that. Now, obviously, sleeve goes in, the probe comes out, the K-wire goes in, and then I have a path from the skin to the inside of the disc. Then, at that point, the dilator goes in, then it's cannula, which is 8 millimeter inside, 10 millimeter outside, goes over the dilator. And practically now I have an 8 millimeter opening from the skin to the inside of the disc. And you see there how the air sucked in, it's already distracted. Now, there's a series of tools, and all of that is right here. As a matter of fact, it's ridiculous how few things you need to do, but you need to use those tools really carefully and very deliberately, and be a master of how to use those things. Like anything else, you have to get used to them. But once you get used to them, you literally can use them to do a discectomy, prepare the end plate, and so on. And it's a lot with feeling. Now surgery is generally a lot with feeling, you know, like you have to use your fingers. Like when I'm going to stop here. When you are on the bone, you feel the high frequency vibration in your fingers. And I think that makes, you know, a huge difference for people who have a good feeling with their finger versus not. It's harder to do any surgery if you don't use additional sensory, like how you feel. But you feel when your metal is scratching on the bone, and that gives you understanding that you are actually on the bone. But then once you have done that, there is a cage, then you pack the place with the biologic, then you put a K-wire in, the tube comes out actually, and down the cage goes in, and then you disconnect it, and then you're done. The rest of it is the typical pedicle screw fixation, the percutaneous pedicle screw fixation. You know, you can use the navigation and so on, but I just can't guarantee you. If you do algorithmically follow certain steps, you are better than any navigation out there, any robot or navigation system out there. You just have to understand the anatomy, understand the pictures, and follow certain steps. Okay, so and that comes from somebody in 1999 to 2002, until I started my general surgery residency in Dartmouth. We built a navigation machine in Stanford. Our next lab was intuitive surgery, which did the Da Vinci robot. I did some models for them. I know this, but I'm telling you, you are going to be better than any navigation machine out there if you just put your mind on it and practice, practice, practice. Okay, so I'm going to stop here. There's no, you just got the essence of 12 years experience here. So I'm sure many things came short, but I'm going to open up the floor to questions, please.
Thank you for coming today and thank you for your talk. I was wondering, have you looked at fusion rates?
Yes, yes. Okay, so let's go back to my talk. I was hoping to talk about that. Now, before we start that, let's look at lots of other things besides the fusion. By the way, these are the instrumentation. This is what you can get out of it, and this is fusion rate and so on. Now, what is the general rate of spinal fusion in Clifford Hill? What's the number? What the literature said? I know it varies, but generally, what do you think it is?
Maybe depends on the time period.
In 1 year, most of the studies they look. I'm going to tell you the result of 500 studies now. Most of them look at 1 year. What is the for Cliff and Hill? What's the rate?
90%.
No, it is not. It has been it's somewhere between 60 and 85. And if anything is 90, they are very, very impressed and low, small. There are some studies that say 90% low number, very experienced surgeon, special group. They don't take any smoker. They eliminate everything. About it's somewhere between 60 and 85%. And there 85 is the higher rate. But that is for Cliff and Hill. What is the fusion rate for like ALIF, XLIF, or minimal invasive muscle sparing approaches? Those are in 90s. Yeah, those are in 90s, okay, but not TLIF. Okay, now when we started that, two independent radiology rate my fusion rate at 98%. I didn't believe that until I looked at lots of other studies. I'm not special. I want to be special, but I'm not. Lots of all muscle sparing have at 90% fusion rate. But let's now we are talking about that. Let's talk about the other risk associated with surgery, because this is important, right? Let's talk about the infection rate. What is the infection rate? I'm not talking about big scoliosis and so on, where just a paper came out, 60% complication rate, 30% just infection rate. I'm talking about general degenerative thing and so on and so forth. What is the infection rate? What should we start? I apologize. Here again, I'm going to put some people on the spot here. What back there. What do you think? No, you, yeah, you. What do you think? What's a regular risk of infection for general fusion in the United States? Very good, actually, 3 to 5%. Okay, very good. I mean, but with lots of, if you have factors and so on, it can go to 8%. But generally, if you're more than 8%, your infection disease department will start looking what's going on there. Okay, what's the infection rate now with minimal invasive fusion? What about you? You mind to just throw a number out there? What's the rate of infection with MIS approaches? Actually, under 1%. Very good. Okay, so I can tell you my data. In 1,600 patients, I had 3 infections. One of them was a 54 BMI, smoker, diabetes. One of them was a patient who had a rheumatologic disease that lost 28 pounds in about a month. The third one, we never figured out that these two had the infection of one of the screw insertion site, but because there is no cavity underneath, because the incisions are not connected, it was limited. 5 days of Keflex, didn't have to take him back. The third one is the olive site got infected. That's the only time that the olive site got infected. We couldn't prove it, but it was a question if this was an IV drug was involved in that and so on. But that patient as well, there's no cavity underneath. It didn't spread. There's no space. There's not a medium there to accept more infection. So not a single take back to surgery. So rate of 0.3% infection, 0 take back to surgery. Let's talk about the big deal, nerve irritation, nerve damage. Okay. Now, who do I pick up now? May I ask you what is in a TLIF flip? What is the rate of nerve irritation, nerve damage? What do you think? Just throw a number out there. 8%. It is actually pretty good. Now, again, I looked at lots of paper. Most of this paper, they look at 1 year. Everybody hush early result. And because early result is not really good if you systematically look at that. And that rate goes from 0.3% in a study that was only 12 patients to 50, another study 25%, but most of studies, they say 1 to 3% permanent damage after 1 year. The early result, nobody talks about that. And when I started that, I separated. I'm going to explain maybe later the study. I start looking at all my TLIF before I start doing OLIF, so no selection bias versus my OLIF. Again, I'm not an academic. I do the best I can, and there are lots of limitations in all my data. I'm the first person to acknowledge that. But when I looked at that systematically, my rate of nerve irritation for my TLIF was 12%. For my OLIF was 8%, meaning 1 in 7 patients almost wakes up and they have some numbness or something in the leg. Now, when I looked systematically, I really went and examined the patient, my TLIF, because I knew I'm going to do that. I went there myself, I examined them, and it's actually 12%, but they never complain about that because TLIF patient, their complaint is pain, their complaint is when they can't get out of bed and so on. But if you systematically examine them, they do have good nerve irritation, they do have good numbness. Now, my OLIF patient, they're ready to go home, but they have a numbness. But doctor, what's about that numbness on top of the foot? I didn't have it before. Has a good prognosis after a year. 1 patient in 303 patients had permanent damage from the surgery itself. And the 5 patients had a non-life limiting numbness. They only noticed they have numbness when they notice that, but it wouldn't limit them at all. So this is nerve irritation. Now, durotomy. May I ask you, what is the rate of durotomy in a regular TLIF? Then, okay, 2%. Who goes higher? What do you think? What's the rate of durotomy in fusion, spinal fusions? Yeah, it's about actually, in average, about 7.8%. That is what's recorded. But this is everybody, okay? This is a fusion. I'm not talking about decompression and so on, okay? Obviously, if you have a redo and so on, it's higher. Not a zero rate of durotomy, because it makes sense. You're not even there. I mean, you have to be a very, very wrong place to have durotomy in this procedure because you're far away from them. but you started that path. Let's talk about the, the other associated risk, general risk of like ileus, the ICU stay, blood transfusion, and so on and so forth. Those are pretty high, but in my group of patients, actually, I have a testimonial of a hospitalist who says since we are doing that, he hasn't seen a single ileus and so on. So there are lots of other risks that goes with that are shorter. So, but it's getting close to 8 o'clock. I know you have a lot of other things to do. So why don't you answer a few more questions? Again, I have the instruments. I have a model. Please go ahead.
So,
I've got a question.
Yes, please.
Can you guys hear me? Yeah. So I'm curious. Thank you for a wonderful presentation. I think this is, it's very interesting and some really novel techniques. I'm curious if you could give advice to the residents. No one is born being able to do a 30-minute lumbar fusion. How, if you think just generally about learning a procedure and learning to be expert in a challenging procedure, what are the steps that you take? What is your advice for how you learn and master a surgical technique?
Well, I can tell you my technique, but I'm hoping nobody will repeat my technique. My technique is being stubborn, not give up, not being persistent. Now, it took me, I didn't, now this was my almost 1,600 cases yesterday that we did it under half an hour. It wasn't my first 100 case. My first case was 1 hour and 40 minutes. I needed additional to that almost 45 minutes to set up the room. Now, my pride is not that I can help this patient. My pride is that Dr. Gasco, after 10 cases, he fell under 1 hour for one level fusion. So my pride is that I have packaged the knowledge that nobody needs to do my mistake. They have to do new mistakes. And believe it, I have done almost all the mistakes. Now, if you algorithmically follow the room setup, the steps, I think after 10 cases, everybody who has done TLIF can do this surgery under 1 hour. And the learning curve, the one I didn't, what I did not show you, we made the science of how to teach this, and we modeled it after aviation. As you see here, after 20 cases or levels, this is for cases, but now we have more data. This is an old slide. After 20 level or 10 cases, you get as efficient as I was under 250 cases. So this is, I'm really proud of that part, that they don't need 200 cases to become as efficient. They can now get with 10 cases efficient. That's part of it is the way we teach it. The second is what cases to start with, but as well the setup in the room, and as well the refining the instrumentation, that they do the job like automatic versus the manual transmission. You don't have to worry about the transmission. You just put it there and things works for you. But I think one of the mistakes I have seen a lot is that you can go to Vegas, you go to 4 hours of cadaver lab and 12 hours of gambling, and then you come back and you can do it. This is not like that. You have to put some good effort to be able to do that. You need a proctoring. You need like 10 cases is not a very high number, but you need 10 protected cases to acquire the knowledge. I hope that answers the question.
That's a nice answer. Thank you very much.
I think you had a question.
can you come back to that picture of the,
This one? Which one? This one?
no, yeah,
This
so.
I've got to run. Hamid, I'll see you tonight. Thank you very much for a great talk.
Thank you. Thank you very much.
So the two questions was, one, the radiculopathy rate, which like usually here we do TLIFs for treating radiculopathy. So the fact that we get post-op radiculopathy is, like, for us, it's a big deal. We see 1 or 2 a year. And we do a lot of TLIFs. So the fact that you have a 12% is kind of like defeats the purpose of protecting the nerve. If you're causing about 12%.
Now, that 12% was the TLIF group, my TLIF group, when I go and examine them after the surgery.
You said that was the OLIF group. And
No,
that's what's
8%. 8%.
But still, 8% is
Yeah, yeah.
really high
It's
compared
high.
to 0.3.
Okay.
And
Radiculopathy or
when-
numbness? Radiculopathy and numbness are two different things. Numbness,
But also in your paper, it's neuropraxia and weakness. So
Mhm.
it's not just numbness, there's permanent weakness.
here, let me bring the result of the paper. I should have it somewhere here. Yeah, go ahead. Yeah,
And
go
then the
ahead.
other
Go ahead. I
part
want to
is-
hear that.
The other part is for the fusion here, how much, how much sagittal correction
Mhm.
and this, distraction you get, because I'm looking at the picture and the second space looks still collapsed.
Mhm.
And all the cages have subsided into the
Mhm.
end plates. So, and
Excellent
like usually,
question.
usually you get like at least 10 or 15 degrees of correction with A-lifts. If you're doing a big T-lift, you can get also 8 or 10 degrees. It's maybe 2 millimeters.
So, you asked 5 questions. Which one should we start with?
We have till 9, so.
You have done to 9. Good, good. Then we have time. Okay, so let's start. Let me go to the. You can imagine, I have been asked that question 50 times, each of those questions, at least 50 times. I have actually a presentation for that. Let me bring that presentation up. And again, this is just one tool in your toolbox. This is not supposed to replace all your tools. But let me go to presentation. Let's go to masters. And OLIF objectives. Let me look for it. Here, objective master. Here we go. So, nerve root irritation. Here we go. Objection 1. Yeah, you actually recited those objections in the same chronological order people are asking. So let's go over that. Now, number 1. You said you see radiculopathy after the surgery once or twice a year. What's your volume of TLF here?
We do like 200 to 300
So you're saying me your rate of radiculopathy is 1%,
less.
less than 1%.
Yeah.
Radiculopathy. What about numbness and so on?
No.
You never see that?
No.
Then you're the
Usually
best-
Their pre-op stuff stays the same.
Yeah.
It doesn't go over.
Yeah. Well, I can just recite you the studies. Okay. In most of the studies, they never talk about the early result. They all talk about the 1-year results. And I want to learn that actually, because one of the things is, early results. For early results, you have to go each segment, examine the patient, each dermatome, to be able to say if they have numbness there or not. Regarding pain, how do you separate the pain before and after the surgery? You have to go. Now I have a good understanding. And these are structured studies. These are not gut feeling. Okay, so for that, I can guarantee you the studies don't support your claim that it's under 1%. The studies are much, much higher than that. And as well, the 1-year results are out there. And there's a list of 250 papers that Mitchell and John Siegel sent all those papers. I will send you all those papers that are peer-reviewed published. Those results say the rate or average accepted rate for nerve injury after TLF is 1 to 3%. And the rate and this is permanent injury. But I can tell you that when I literally examined every segment before and after, the rate of nerve irritation, we separated in 2 categories: nerve irritation versus neuropraxia. If they had 3 or more or less weakness, we called it neuropraxia. I know, Dr. Nato, you have to go, but I want to spend some time with your resident.
No, not that I have to go. I think we should continue.
No, absolutely. That's the part of the thing I love.
I mentioned earlier that, Dr. Al-Nurani is one of our lead critics of almost anything you.
But those are the best. Those are,
And, I think it's really wonderful, that we have this in our environment, you know, that whatever you do, you're gonna get some pushback, from some direction.
that,
Just, if you think it's bad for spinal fusion, wait till you do trigeminal neuralgia and then find that everyone is saying, why glycerol, why not balloons? And why, there's publications out there that say this, we could go on and on, I'm
but those
sure.
are people who change their path.
Yeah,
People who
but-
question everything.
yeah, and I think that's wonderful. But listen, I wanted to give you this, you know, Louisville is famous for the bat production in baseball, and baseball is sort of the American, quintessential
is.
American summertime sport, you know, hot dogs and it's a sport that you can leisurely observe. It's not like the football where something's happening all the time, that it's episodic. But anyway, the bats are made here, and so Louisville, this is an iconic, this is an iconic, we'll come up here. This is an iconic, reminder for Louisville, and if you think you had trouble getting your artificial spine through the TSA, don't even try with this. We'll mail it to you, okay?
No, actually, I'm going to check it in, actually. Wow, thank you. Well,
Yeah.
thank you very much. I'm going to use it at work once in a while. Thank you so much.
All
Well,
right.
now, no,
So now-
we have 1 hour time, right? Because I want to, I like cricket. Because I was extremely critical myself. When I went there and watched that, I said, you know, this is something that I'm going to use for a very small amount of my surgeries. And I did. I used it for a very small amount of my surgeries. I was very critical even of the indirect decompression and so on. And I totally understand the critique that a nerve injury is a big deal. Now, that when I start literally looking at the pre-op and post-op, I noticed 12% of my TLF patients, so I'm not as good as you guys are here, they had additional numbness all the way down to neuropraxia after my TLFs. But vast majority are obviously just a new numbness, just additional sensory feeling. When you go and literally take those dermatomes and systematically examine them. Most of that after a week or two get better. Now, in the olive group, as well, that rate was actually a little lower. There's a slide I didn't show that showed where the TLF was, where the olive is. There are other things. As a matter of fact, in about a week or two after the olive, to higher rate than TLF, they get worse. It gets even worse. Then is more reason not to learn this. Because about a week or two after the surgery, all the pain gets worse. And the reason for that is the whole we figured out is twofold. There is a worsening of the symptoms about the day 3, 4, and that is if you pass more than 7 times in your psoas. This is a retro psoas approach, but inadvertently you will poke into the psoas. And unlike XLIF, where you slit open psoas, here you're just poking into that, meaning small hole, and then psoas becomes swollen, and then about 3-4 days, they cannot bring the leg up. And that becomes even painful. But then that gets better. And then there is another group of people that about 3-4 weeks after the surgery, they come for the first protocol to visit their wounds and pass. 2 months later, they're not doing that well. The pain comes back. Part of that is related to that they increase the activity too early. But part of that as well is related that, especially in the first week or 2, is that the pressure has nowhere to go. You don't have a huge open space there. The facet is not off. and tissue starts swelling and increased swelling, actually the pain gets worse. So there are, and this is not only my experience, Morgan Stanley
Well,
experience.
what's swelling? Because like you're doing a minimally invasive approach to an 8 millimeter tube, which is even smaller than the MLD tube. The MLD tube is 16 millimeters.
And
This is 8.
Mhm.
There shouldn't be like that much swelling that will come back in a month that will cause so much trouble for the patient.
No, so, no.
If there's also like depression that this causes.
Mhm. Well, number one, I'm just giving you the data. I'm not, and you and I both are speculating why, but this is the fact. About the 1 in 8 patient, they have a temporary nerve irritation, numbness, mostly numbness. 1 in patient in 300, that includes my learning curve, has permanent damage from the surgery. But within 3 months or 3 months, most of these patients improve and they start feeling better and better. And that symptoms go away. And after 1 year, including my learning report, 1 patient had permanent damage to fracture from the surgery itself, and 5 patients had still numbness that wouldn't limit them in the surgery. And I can just tell you, I can send you all the paper I have, and you should follow up on this. That most of TLIF surgeries, they have a much higher actual rate of nerve irritation. So you have a fantastic result here. I'm not going to dispute that. Good for you. Publish your paper. Okay, but studies, that rate is actually 1 to 3% permanent damage from the surgery. Alone, macrodiscectomy, they have 0.8% risk of permanent nerve damage. Okay, so this is what's published out there. Now, again, the nerve irritation most of the time get better after 2 to 3 months. And there is, we give the gabapentin, we understand it well enough to know what to do when that happens. Now, let's go to you had another objection about, what was your second objection?
The sagittal correction.
Sagittal correction. Where did all the sagittal correction, lordosis and so on, where did it all came from?
Actually from here. So for the
Good.
Letterman group is actually here.
Rotman
Dr.
group, yeah.
Glassman.
Okay,
So, and it's the most commonly, it's actually the most validated thing, which is sagittal correction is the only thing that actually helps back pain and correcting the sagittal deficit. So, and
But where did it originally come from?
again, Glassman and France. But
What was the study about? I mean, what group of patients did they study and so on?
patients with back pain and like spinal deformity.
Well, I'm not a deformity surgeon, but my colleague, Dr.
You technically are. You're showing scoliosis correction. That's deformity.
Deformity surgery, I mean, it's a field for itself. My colleague, Dr. Sonny Kim, he's a deformity. He has 35 years of deformity. He has done probably 6,000 deformities. And there is, I think, before I get in the field that I'm not an expert on, he has actually get that video from Dr. Kim regarding when he's talking. The original things for the deformity parameter came from juvenile scoliosis. Those numbers are very, very valid. Those numbers come from this young patient, 15 years old, 16 years old, after the puberty. They have to live with that back for 50, 60 years.
Yes, that data got upgraded for adults, and there's updated data for how old you are. So like you don't have to fix everybody to 5 centimeters like everybody else. If they're 7, you have to get them to like 6 or 8.
Okay,
So
well, now
the
let's
data
say
is
right
also updated for all people,
Yeah.
and it's also updated for. So the data that Glassman came up with is mostly what improves their pain, not based on juvenile and 16-year-olds. So it's like, if we got somebody to this correction, did they improve or not? So it's mostly about patient outcomes.
Now, let's go back
And
to,
the other part is like, so there's 2 kinds of spine surgeons. There's people who fix deformity
There are people who like.
Yeah, that's
cause
what Shapley
deformity.
says, that's what
Yeah, so
Shapley
that,
says.
that's
It's
the.
very
so nobody
fashionable
can
thing
say-
to say these days.
Nobody can say, oh, I will fix deformity, it's like, if you're not cognizant about that part, then you're missing a lot of patients.
Yeah, well, those, I'm fixing the, okay, let's go talk about the deformity. Okay, let's say your goal is to correct the lordosis from 7 to 11 degrees. With the one level fusion, are you going to fix that with the one level fusion? No, you have to do more than one level, or you have to do osteotomies.
No, you can do that, so like the quoted TLIF data is
Mhm.
8 to 10, if you're doing an open TLIF, you can get 15. And if an ALIF, which is the most aggressive one, you can get 15 to 20. And the other part, which is like, if you're not getting like any height difference, that defeats the whole premise of indirect decompression, because if your disc space is collapsed, you didn't get any indirect decompression.
What is the indication that you did enough decompression? Is it the number there? Or is it what patient tells you?
Well, if you're gonna go by that, your data shows that only 72 have some improvement, but actually the result, like the radiculopathy goes away only in 38%, and you cause radiculopathy or neuropraxia in 12.
Mhm.
So it tells you that your decompression is not good enough.
Now, if what patient tells you, when patient wakes up and tells you the leg pain is gone, is that good enough indication for you that the decompression is adequate?
Yeah,
Is that enough?
yeah. They come for you because they have a disc herniation with a radiculopathy. You take that away, is that what you need to do?
Now, what about even if those patients who have nerve irritation, they tell you the preoperative leg pain is gone, what about that? They have new leg pain that, or numbness, mostly numbness, not pain, numbness. But what if I tell you that 95% of the patients who had radiculopathy, they wake up, right when they wake up, when they tell me the leg pain is gone? Is that enough for you? Is that enough?
No,
for
but
you?
but then your data that you published is not wrong, it is wrong.
Well, I published my 300, I didn't
I know,
publish
but
my
like,
1,000 patient yet.
I know, but like you're saying, your data, you just said 95% of your patients have no leg pain when they
Which
wake up.
paper did you read? 303 patients?
The 187.
187?
Yeah.
What do you mean? I don't have 187. I have a
There's a
one.
paper that says 187.
I have my paper, sir. Will you let me bring this up?
No, 187. I'm saying curious.
Okay,
It's-
here. So there is a paper, proof of concept, 68 OLIF, 58 TLIF, and there is another paper, clinical outcome is 303 patients.
No, there's an OLIF data retrospective that you published.
I
You're the only person on the paper.
show it to me.
Yeah, okay, pull it
Which
up.
one is it?
Send it to
Read
me.
the, no.
Physiologic decompression of lumbar spine.
Oh, you mean that patient? That's
Yeah.
not, that just, okay, that is
It's
the,
all your radiculopathy patients.
okay. So, now,
And in that data, you say the radiculopathy is gone and only 38%. You're telling me it's 95%. So which one is the right one?
so well, now we have done 1,600.
Uh-huh.
We haven't published that yet. And that over 90% of the patient wake up, they may have still, no, again, that number is 1 year out of surgery, right?
Okay, numbers again.
Okay,
This is numbers. You said you did 1,000 cases. You're showing us data for 200 that doesn't hit the resolution.
mhm.
200 out of 1,000 is 20%. Your radiculopathy rate should be at least 80, and now you're telling me it's above 90.
Yes, that's what I'm telling you, because I have no 1,600 patient. And we are publishing right now our 1,000 patient. See, you see, you
But
take a
no,
snapshot
No, but you
of
said, so everything that we've done is OLIF.
1,600 is OLIF. 1,000, I have done 1,600 OLIF. I've done 6,000 surgeries and I've done 1,600 OLIF in the last 12 years
I thought you were, in the beginning, you said you've done 1,600
of OLIF.
cases. Oh. Okay.
So this is a movie. You're taking a snapshot. I think that's where the confusion comes from.
Yeah,
Now,
the spine surgery has reintroduced, a rather previously very criticized notion of self-reported outcomes.
mhm.
and that, you know, patients with pain are often described as suggestible, like if the pain went away, they're suggestible, and it didn't go away, well, maybe they have other emotional factors.
And they are, we consider them as
The
well.
self-reported outcome had sort of a bad name, but then in the spine world, we had many criteria, like what did the anatomical correction look like? What did this type, what was the fusion rate? Or there are all these surrogates for what did the patient actually think about his outcome?
So,
And I think the self-reported outcome became re-legitimized, if you will, because these other factors could be quite good and the patients weren't happy. And in other circumstances, the patient's happy, but these other criteria are not necessarily happy. So, what I'm wondering is, when you look at your results, do you have a self-reported outcome kind of index for that?
osmometry, I've used osmometry and I think it's very valid. See, I do have a problem that people try to fix lordosis rather than the patient. You remember Patterson was telling us, fix the patient, not the number, not the picture. You can go Photoshop it if you want to fix it. No, when you get to real work, you have to ask a patient, what do you want to do? Most of these patients just want to be able to walk without pain. They are okay even to having some pain. They go to 5 surgeons, they look at their lordosis, they say, there's no way I can correct your lordosis without a 3, 4, 5, 6 level fusion, and they are sent away. They say, you cannot have the surgery. And this patient, they come, we do a very limited surgery that doesn't fix their lordosis. Sometimes it does, sometimes it doesn't. As a matter of fact, we can correct the coronal deformity 5 to 7 degree, and I really appreciate you have read those papers. That's what being prepared means. And we haven't done any study on the coronal deformity, but to a certain degree, you can fix that without osteotomies. If you need to do more than that, you need to do osteotomies. Then you're talking about a different kind of surgeries. And sometimes there's a legitimacy to do that, but you are not going to do that surgery on an 85-year-old person who cannot walk to the kitchen. That is, you have to weigh and balance risk versus benefit, what you want to do. Now, there is coming back to the deformity, based on the conversation that I had with Dr. Kim, most of these parameters are taken from juvenile scoliosis. They have some validity, but there's just recently a paper came out there. Now, those have to be age adjusted, meaning that don't try to correct the deformity to the time patient was 25 years old. Try to correct it about 3 years before patients start having symptoms. And I do believe there is a manic thing going on in the United States to correct everybody's spinal parameter to the time they were 25 years old. And then the price is you have to do more surgery, bigger surgery that actually backfires. So I think this is just the philosophical differences that you and I have. That I don't believe that every deformity needs to be corrected to give patient clinical symptoms, but we won't be settling that in the next half an hour. Respect.
So it's not my philosophy, it's like what the published data shows. But it's also like you don't correct every deformity. If the pain generator is their deformity, yes, you have to correct it. But if they're coming to you with a radiculopathy and they have a mismatch on the lumbar lordosis, you don't care. I don't care about the lumbar lordosis. I just care, do I need to treat the radiculopathy or not? Those are 2 different things.
So you are caring about if the radiculopathy after the surgery goes away. Or 1,000 studies, see, you have to have follow-ups. I have 1,600 patients, or I'm still working and beating my system. See, I don't have resident and so on, so it takes a lot more effort for me. But our 1,000 patients are being compiled, and I will make sure you will be the first person to get the data, what the rate of radiculopathy is gone. But let me just tell you something, right? Patients do matter to you. I have the feeling they do. So 2 months into that, I could not see, do you know Carl Sagan, right? He said extraordinary claim require extraordinary evidence. And meaning that I know what question I would be asked, because these are the same question I ask. Again, I'm not telling you stop all the things you are doing. I'm telling you start looking into this because it's an important tool. Now, 2 months into that, my patient came to me and told me the leg pain is gone. And I said, when did the leg pain go away? Oh, my back hurting me, but the leg pain went away when I woke up. That's what they told me. I'm a busy man, but I still took the time taking patient testimonials, literally having them on the, I have my OS history, I have my follow-ups and so on, but patient stories matter. I start taking patient stories.
But again, but you just contradicted what you just said, because you said you need extraordinary evidence.
Now,
Showing me 1 or 2 patients that are happy. is
1
not
or 2 patients, what about 1,200 patients? Here,
But all of the, I like patient satisfaction score across 1,000 patients
Okay.
are happy.
let me show it to you, okay? So I just put OLLIF in YouTube. So at different stages, I'm just going to go down. I don't know how fast your thing are. Your internet is here. And my testimonial will start. And you can sit here for 1.5 hours, just scroll down. These are not my patient, but here's my patient. And you just go there for almost 1.5 hours. Just scroll down and patient tell me, yes, they have back pain, yes, they have nerve irritation that got better after 3 months. But over 1,200, not 1,200 patients, 1,200 patient testimonials, because same patient sometimes
So you
1 month later.
You filmed every patient you operated on?
Not every patient, but a lot of them. Yes, I did. And I record every single patient I have surgery. I record our conversation now for the last year. So 1,200 patient testimonial, they say they describe it. I say they had back pain, but the previous leg pain they had before the surgery, they woke up, that was gone. These are all my patients at different stage, like right after the surgery, 1 month after the surgery, 6 months after the surgery, 1 year after the surgery. So these are all my patients. 1,200 patient testimonials online. I took my time to get those testimonials. And Amanda will send you a list of that. But I put as well those people who had nerve damage. I put them there, they describe it. I put those patients who had not the best outcome and so on. So because you always will get them. So, but unanimously, what you hear when you start listening to 250 of them is that they say, yes, they had back pain, but they woke up, the leg pain they had before the surgery was gone. Now, this is not a study if it's, you're right, a handful of that. But what about if it's over 1,000 patients? Now, they may have nerve irritation, but they can say that nerve irritation, again, you recite 12%, but in my initial paper, it was 8.2%. The 12% was TLIF, and it was a learning curve. And I just can tell you that most of that is temporarily numbness that gets better. No, but we don't have much time. I will continue that conversation. I'm not sure what we are doing today, but I want to talk to you way more than just today, if you want to take the time. But you talked about subsidization. Let's talk about subsidization, right? I had to get very, very familiar with the physics of CT and films because I had to take the picture, register them, make a 3D anatomy of that in a virtual reality model, and then cut them in different directions. So let's go here. Now, when you get a CAT scan, as you know, what you see on the screen is not the actual film. As a matter of fact, you would be scared if you would see the actual quality of the picture. What is the grid like? Let's start with MRI. What is the grid of regular MRI? 256 by 256, and usually 2.5 to 2.2 is your high resolution 1.25 millimeter. This is the grid, the voxel. The grid for regular CT is 512 times 512. That the old NTSC in TV has more resolution than the regular CT. The thickness of the slides are usually 2.5. In a high resolution, they are 1.25. And what it means for actual picture, most of the things you see on the CT on the screen is fake. The computer, to give you a smooth picture, you need to know that to interpret the data. Now, imagine if you take the spine as this, and then you see this, then you have subsidation. By the way, even if you see that, and if it's less than, if depending on the CT you get, if the CT is 2.5 millimeter, which is a standard, anything less than 2.5 might be, might not be, it doesn't really matter, it's not accurate enough. If you get 1.25, then everything less than that amount is not real. Now, but that would be in a regular CT, because you cannot look at this. That is what I'm trying to tell you. You cannot look at one picture and diagnose subsidation. Then the physics of it doesn't work that way. But additionally, let's say even you understand that spine, the vertebral body, the end plate is not a flat surface. It is actually a concave, convex surface, and the CT just averages it. What that means is that, again, if you see a picture like what we saw here, and you say every single level is a subsidation, then you have to understand the physics of the CT to be able to really say that if it's truly subsidation or not. What is a better way of looking at the subsidation, because we don't have to reinvent this, is looking at the interpedicular space before and after, because that is a space you can accurately measure, and then you can say you had a subsidation or not. Now, for all practical purpose, the interpedicular space is the best indicator for true subsidation, because what you think, you just look at the picture cage, one CT, one picture, and you say you have a subsidation, the physics is not supporting you. But if you look at the interpedicular space and measure before and after, then you can truly measure the subsidation. Now, I can just tell you what the rates are. These are the numbers. When you systematically look at that, at beginning in my learning curve, in the first 300 cases, I had 8% risk of subsidation, but only less than.
The picture that you're measuring, like there's a hyperdensity in the foramen that we're ignoring.
Okay, no, but let's talk about that different, because you're mixing now. Let's talk about subsidation, then we can't talk about it.
If we're gonna, I don't know. Let's ignore that. Let's ignore that picture. We're gonna go by the new measure of subsidence that you're measuring, which is the foramen size. The foramen is not actually 14 millimeters, because there's hyperdensity in the middle of the foramen in that picture.
Are we talking about subsidation, or are we talking about not enough decompression?
No, you are saying that the way to measure subsidence is how big the foramen is. This is literally what
No,
you're showing.
I'm telling the
You
way to
just said
measure.
that.
No.
This is the title of the slide.
So do you want me to tell you what I want to tell you, or you want me to tell me what I want to tell you? This is going to be either that. You can tell me what I'm telling you, or I can't tell you what I'm telling you. So these are two different issues that I think you're very clearly are completely confusing. Let's talk about subsidation, meaning you lift it up, and then the cage breaks into the vertebral body, and then practically you start to building right back. Okay, now this is one case, and you cannot look at the cage. That's what I'm telling you. physics is not on your side. You cannot look at the cage and relationship to the end plate and say it's subsidization, except it's truly digging into, and it's more than 2.5 to 5 millimeter ratio. Now, the best way to look for subsidization is to look for in the particular space, to measure it before and you measure it after. And that is a better way of looking for subsidization. I will promise you I will come back to your thing. You just let's stay focused now. Okay? The rate of I measured the rate of my subsidization in my first 250 days was 8.3%, meaning almost 1 in 10 of my patients did have radiographic subsidization, which is not equal to clinical subsidization. The clinical subsidization meaning that you get that, you do have true subsidization, not like looking at one picture and from you have true subsidization, less than 2.8% of them was clinically relevant, meaning that they didn't have leg pain, but then they had subsidization, then they had leg pain. Now, what I noticed that I was over distracted. I was putting, now when I was doing killers, I was putting pH 7 to 10. And when I start doing this, I didn't believe in indirect decompression, so I was putting pHs up to 15. So my subsidization rate was really high. What I did, I reduced my cage size 3 size down, 10 to 13 is not of the cages I put now. My subsidization, true subsidization rate went from 7.8 or 8%, went down to 3.7%, something like that. But the clinical relevance of that was even lower, like about 1.2%. But I did not lose any positive results. This is the data that I have gathered that it says that I was over distracting in my initial learning process. Now, having said that, now it comes about back to, if somebody has a, bony thing there, I didn't remove, because if that's a problem, I can tell them indication where not to choose that, because all the mistakes you're accusing me, I have done it already. Yes, you're absolutely right. There were cases that patient had the foraminal stenosis that I didn't remove. That number is that in since last week, which I have done over 1,597 of the surgeries, in 13 cases where I wasn't expecting to go back, within 3 months, I have to go back and do additional foraminotomy. 13 cases that have gone, no, some cases, like I have a grade 2 spondylolisthesis, there's stenosis there. I know I'm not going to be able to correct that. I go and do a very mini laminectomy at the same time. I do as a matter of fact, I do usually the laminectomy. I do go pretty 1.5 inch midline. I go down very minimal laminectomy, then I do the order. I would say probably 50 to 70 cases in a year, maybe less than that. About maybe 40 cases a year. I can look up the data for you if you're interested. I do a laminotomy. I don't do laminectomy. I do a full unilateral total. I undo over, so-called over the top. I open up the space, and then I give them time. If they usually their right clover to get better, then I'm good. But if their back pain insists, then I already have done normal, usual decompression. Then I go and fuse them for axial back pain. Now we can jump as well to the next level that axial back pain doesn't exist, right? Because lots of people say axial back pain. In my practice, axial back pain exists, and fusion is a good solution for that. Now, talking about this, it might be a foraminal stenosis, it might not be a foraminal stenosis. The way I deal with this piece is talking to the patient. If patient has still symptoms, then this is going to be one of our patients that will go back and get a foraminotomy. If this patient doesn't have clinical radiculopathy, I'm not going to touch that. Now, there's another thing that many of my patients, no, this is true. As a matter of fact, let me show you something there. This, right here, this is truly osteophyte. This might be part of the problem. And This as well seems to be part of the, osteophyte. But if you look carefully, there's a little fluffy things out there, right there. That so often in my picture, if you look at a lot of my picture, you will see something with bone density in the foramen next to the disc. This is so-called tricalcium phosphate. I'm going to give you a sample of it. It is a tricalcium phosphate, obviously calcium, which will show up like bone in this. And one of the, I tried 5 different biologics, and the reason I said continue using tricalcium phosphate is I'm going to actually use this treatment, and that's the reason I used that.
But that's an osteoinductive, right?
No, this
Or
is
is it
a
a
ceramic. That tricalcium phosphate
Okay.
is a poor biologic.
Okay.
This is a poor biologic, except you mix it with bone marrow in a very specific protein. And we examined that, we took the bone marrow, then I put the Jamshidi. I start my surgery by putting a Jamshidi and picking bone marrow. And I don't spin it, I don't do any of that. I just put it on in 3 to 5 minutes. And the consistency of that, first of all, it becomes very malleable. It's still in the CT, looks like bone, but it becomes very malleable. After 12 minutes, this has consistency of gel form. So I'm going to give you each of you a piece of that. Next time, when you're in the water, just put water or normal saline on it. This by itself is a very poor biologic. May I give you one? This is by itself, sorry, we don't have enough of that, but no, do it just because it is important. These details do matter. So take 2 pieces of it, put it 3 to 5 minutes. Now, why from each bone, I take 5 cc of bone marrow. 5 cc, because after that, what you get is not bone marrow, it's blood. How do I know that? You can literally take it and mark them with your fluorescence dye and look under the microscope, HCC. It just drops after 5 cc, just blood what you're getting. Okay, so, but this by itself has a miserable fusion. But if you mix it with stem cell, bone marrow, not blood, bone marrow, the fusion rate is as good as DPM, if not better. But it's not as good as the bone morphogenic protein, but it's as good as if anything, better than DPM. No,
Osteoconductive, it's a scaffolding, so you should expect it should resorb and bone should be there within a year, right?
yeah, I mean, it does happen, but that by itself, when I was using this without bone marrow, my fusion rate was miserable, not good. Well, miserable, I mean less than 0. Okay, with the DPM, okay? But if you use that, but there's a problem here. It's calcium.
Mhm.
If you get a CAT scan, in the CAT scan, it looked like you have bone in the foramen. Not this one, but in many of my pictures, you see like bone density in the foramen, or even radiologist calls me, patient is doing perfect, no problem. But you see that there. But once you have it 12 minutes on the bone, on the blood, bone marrow fluid, just touch it. It has the consistency of gel form. So if patient has foraminal stenosis, it's not because of that, but here look like that. Now, it's important to distinguish between if it's bone, osteophyte, or this. Either way, in 13 cases that I wasn't expecting to go and open up and do a foraminotomy, I had to go back in and do a foraminotomy. This is the data. Now, let's go back here. So lordosis we talked about. I think that's a continued conversation, which I always welcome. Objection 5. So that was for me a big deal. I did not believe in indirect decompression until somebody much wiser than me told me, then stop doing ACDFs. If you don't believe in indirect decompression, don't do ACDFs, because 9 out of 10 times, if not 19 out of 20 times, when you do ACDF, that's what you're doing. But I didn't hear that much objection regarding that. Most of people who do XLIF, ALIF, and I'm assuming you are a big advocate of ALIF. You So then I don't have to convince you. I don't call it indirect decompression. I call it anatomic physiologic decompression, but it's the same. Now, the other objection. That is, the question is, because when you do that, you know that maybe not as important for you right now, but when you go to private practice, you have to make money, otherwise you cannot pay your people. Anybody here that going to be, private practice, and you guys plan to do that or academic and so if you're not going to private practice, not important for you, but the financial of your life does do matter. It make you break. And I couldn't do anything if I couldn't pay my staff, and it's hard. It is hard. Okay, so, but now all of a sudden you have a surgery that is like ALIF with posterior fusion, and it makes a huge difference in practice. And some people say, why do you go to that 360? Because you're anterior to transverse process, you are literally in retroperitoneal space, and that's definitely the code. Another thing that I think is very important for this surgery is that you don't have a model of the spine here, do you?
We have one in the Western conference room.
No, we don't have much time here, but if you are interested, another thing that's very important here, I do a posterior fusion, not instrumentation. Do you mind to come and help me for a second? So you remember, you have let's put that here. You have a K-wire in the pedicle, right? The orientation of the facet to the pedicle is medial superior, correct? Let's say this is superior, this is inferior, this is medial. So, and there's a K-wire here. Over the K-wire, this, as you see, is eccentric. It goes. Practically, this is centered on the. I don't have my K-wire here, but then it centers on the facet and literally grind the surface of the facet, which we then pack with biology, and then pack it inside of inside of the facet. So practically, I want you to put the K-wire, so I don't have it here. So this is additionally posterolateral fusion, not instrumentation, which are different codes for that. So I'm just going to come to the end here. Objection 7, fluoroscopy. Everybody's concerned about fluoroscopy. I didn't hear that objection here. We are actually running a study right now where we're just measuring that, but based on the things that we have measured, if you use a modern SIOM, meaning SIOM that are produced after 2000, they have intensifiers, they have things that they use 1/250th amount of radiation. But I just can tell you that in the first case I did, for a vulnerable fusion, I needed about 4.5 minutes taking a natural combined X-rays. Now I'm down to 90 seconds for one level for X-ray. So, but it's always a consideration. Now, there are methods to avoid that. That goes beyond this, but there are lots of methods that you can reduce the radiation, but as well use the physics to your advantage. How you position the SIOM, how to, how to shoot back. One of the things I do now is that I get an X-ray, a bilateral, then I do a series of things, then I get another X-ray. So, but you get more X-ray exposure than a TLF, definitely. Do you guys use a SIOM or X-ray for TLF here?
Navigation.
Oh, you do navigation. Then, as a matter of fact, as a surgeon, you don't get much exposure at all. But here, you get more exposure. What system do you use for navigation? Okay.
Oh, the navigation, it's Medtronic.
Medtronic, stealth. Okay. Okay. So, now this is. Let's come to a conclusion here. Okay. If you need more information, I'm happy to provide it to you. We have every first Saturday of the month, 10 to 11, we have a case conference. And if you want to present data, cases, come and present them. And we have people from around the world joining us. And this is just one tool. That doesn't replace all the other tools in your arsenal. But it's a very powerful tool if it's chosen properly. And for most of my patients, though, I can just tell you, are patients that wouldn't even qualify for all those other kind of surgeries because of the risk versus benefit ratio. So I'm going to stop sharing my screen. We are about, I guess, 8 minutes out of 9 o'clock. So how is life as a resident in Louisville?
Good, busy.
It's busy. This is good. Now, do you guys get exposure to cliff? Excellent. I didn't hear much excellent.
We do excellent occasionally. It's pretty selective. Flip, we don't believe them. And it's mostly A-lip and T-lip.
Now, do you guys get exposure to freehand instrumentation?
This week we did our,
Yeah, no arms broke, but otherwise.
There is actually a picture of me fixing our C-arms in my surgery. Because they're actually just a small computer, that's what they are. But they will eventually fail. I mean, that's normal. And in most of the places we will go, well, if you go to university, that wouldn't be a problem. But I think it really I'm a little concerned about that, that exposure to freehand instrumentation get less and less, not only here, in most of the places. So I would say if you have access, I don't know, if you guys have access to some community doctor surgeon, get that much of exposure and trying to still freehand instrumentation. This is a skill. It's going to take you out of, it's going to save you a lot if you have more experience with freehand. Get every exposure you can use for freehand instrumentation. It's important. Then you guys do capoplasty here in this one?
For cancer pain.
No, but I'm sure your radiologist do capoplasty, right?
No,
They don't do capoplasty?
The radiology groups changed their mind for a while. They used to, but they flip-flop about it.
If you have anybody doing capoplasty, go in with them, try to do that and so on, because that same stuff. That is how I learned my clinical school instrumentation from capoplasty. True C-arm is that's what I learned as well in Galveston actually. From radiologists, there are two C-arms set up for capoplasty. And it's a very powerful way of learning critical screw, critical screw placement. And regarding the ALS, no matter where you're going to go, somebody else has to open for you. If medical legal exposure is way too high, you do it yourself, but there's less than a handful of actually shafts doesn't only ALS exposure. So
they don't do those.
Shafi?
Yep.
I thought you told me in one of the conference personally that you
Yeah.
don't know.
The
That
Brian
was
Wil-
years ago.
Brian Williams is one of the attendings here. He trained with UVA both at Dale. They did 0 anterior approaches in their residency. And they trained with Shafi.
Oh, that's interesting. He told me personally that he doesn't use access surgery in one of the conferences.
Yeah, no, Brian doesn't.
Well, yeah, I use the access surgery when you do ALIF. Is the access surgery vascular or general surgery?
There used to be transplants and then now they're just,
How long does it take to do that?
10 minutes.
That is done do as many ALIF as you can.
Yeah, the reframe, like an ALIF is basically ALIF with the back part, you're done. From 7:30 to 9, you're done.
That is done do as many ALIF people visit YouTube. That's how I started. And in Sioux Falls, my access surgery would take 20 minutes to give me access. And I went to a new place in Minnesota. I'm not kidding you, 3.5 hours for getting access. And that's, I have heard, is not that unusual. Not to, and that become a really bad surgery if you need 3.5 hours for the access. Now, the navigation is a very powerful tool for most of the instrumentation. But again, you know, Stealth is a good system, but matter of fact, Stealth got most of the, you know, your algorithm. The person who did it for them, his name is Russell Codden, who used to work with us in Stanford. Do they use the balls, the active or passive? Do they use active or passive registration, the reflective balls, or do they activate LED, the light LED? Because at the time I was using them, they had this active tracking.
The O arm itself is active. It's like actually spitting out an LED, but the tools are passive. They're the reflective
So
balls.
the registration, the DRF is the active. That's much more active than the passive, the ball, and it's much more active. But we did a study that every segment you remove from the registration, you put your DRF on iliac crest, or what do you do?
If you're doing yeah.
So you do that, so iliac crest to the sacroiliac joint is one segment, second to L5 is the second segment. Every segment you move, you add 15% inaccuracy, even if you don't bump anything. So obviously you guys are, I'm sure, well familiar with that. If you are going to use only one registration and go from the farthest you can to, it looks like, you know, if you're going to do a 455S1 and your registration is on iliac crest, do the 45 first before you do 5S1. I'm sure you guys do it already. Sacroiliac joint, that's my last question for you. You have 2 minutes. Have you guys started looking?
No, none of the faculty.
No.
Yeah, the consensus across all the faculty that like sacroiliac SI joint pain is real, SI joint fusions are not advanced.
Have you looked at all this data from University of Minnesota?
We've looked at we've discussed the randomized control trials, that there's a reporting bias in it. We've discussed it a couple of times.
Well, I'm just telling you, these are the most appreciated patients. They, you know, they come and they literally stand up in the office and they hug me because for years nobody could help them. I do a 15-minute, 20-minute procedure. They literally go back, they regain their life, and some lots of them are younger patients. So just please stay as critical as you are. Stay critical regarding everything. Twice a year, keep looking at this. Okay, this, I think it's going to make a huge difference if you go to private practice. Okay, well, thank you guys. I really appreciate all your time. Okay, thank you. I think we need to stop this, right? Okay. The few, the crowd, like the Marines. Okay. Let's go find Dr. Malta and then. Oh.
I guess I disappeared at the wrong moment here.
No.